All right, everyone. Kim and I are very pleased to welcome you to the Open HLH MAS discussion session this afternoon. I'm going to let Jan Inge make a couple of housekeeping announcements first, and then we will get started.
Welcome. So you may have heard this before, but I repeat about the City Hall tonight. So the City Hall reception is at 7:30. The doors are open between 7 and 7:30. Then they are closed. So you better be there in time. This is only for pre-registered guests, so you need to know that, and you need to bring your ticket with you. Okay? And to get there, you can take the public transportation that is just outside on the other side of the street. There will be guides from our team, Nichols and Sabina. They will be outside of the registration desk. They have a purple end of the name tag, Nichols and Sabina, and they will tell you how to get there. In case you want to go by yourself, you go the blue bus number 3. Long blue bus number 3. It says South Hospital, but in Swedish, which is Södersjukhuset. Sorry for that. We couldn't change them doing that. And then you go by the bus all the way to a brownish brick building, which says Stadshuset, which is City Hall. So that's the way you can go there. But the doors open at 7, and you have to be there no later than 7:30. That's the main message.
All right, give me just a minute to bring our slides up to begin. So again, Kim and I are both very happy to welcome you to the HLH Open discussion session this afternoon. We have a packed agenda. I am sure that you have already noticed this. We are going to hear about current efforts in our field. We encourage questions and discussions. Most of the abstracts, or not abstracts, but most of the presentations are going to be set for about 8 minutes to hopefully leave 2 minutes each for questions. We do encourage all of our speakers to speak to time because we don't want to be here much past 6 p.m. tonight. So please be aware of the time and try to wrap up when the timer goes off. We are first going to hear about working group updates. Our first speaker is Karin Beutel from Children's Hospital München in Munich, Germany.
Yeah, thank you, Kim and Rebecca, and yeah, that's fine. Okay. So I'm glad to be able to present data from our working group. It's the HLH, Late Effects Working Group, and these are the main members. And we had, in essence, several questions. The background is that there is no trials anymore where people or patients are followed up in a systematic manner. So we thought we need to establish something to know what is the late outcome of those patients. We thought that there is an increasing number of patients, and we don't know anything about transplant and maybe not transplant-associated late effects. So we wanted to analyze the existing data and, if possible, also collect new data. So we started out first with a literature search, which we did with the help of the Karolinska Library and a fellow from Seattle. And almost at the same time, we started a collaboration with the EBMT, initially also with the CIBMTR, to get data, follow-up data on patients' registers in these big registries. So the register research, we collected more than 1,000 papers, but we found that only 9 of them had relevant information, and 3 of them had more other conditions included than HLH patients. So there were six papers left with information on about 261 long-term survivors with a median follow-up of about 5 years. And the frequency of late effects was very broad, between 7 and 57%. So this is the summary we made of those relevant papers, and I don't want to go in detail due to the time, but what you see is neurologic dysfunction seems to be a major problem, irrespective of the frequency that has been reported in those papers. So we concluded that there is a need to evaluate this in deeper, and there is not enough data in the literature. We presented these data as a poster presentation already in 2019, had a publication submitted that was rejected at that time due to the, they said it's outdated data, we should make an update, which we did, but we didn't find many more papers, only one more was identified. So in between, we had this collaboration initiated with the EBMT, and then we decided to focus on this project because we thought we won't draw more data out of the literature. This collaboration has been partly funded by the Histio UK, and as I mentioned, the initial CIBMTR collaboration did not work out due to personal and organizational reasons, unfortunately. So what we did is we wanted to include children and who had the first transplant for primary HLH and where there was data available at an EBMT center. The period was chosen 2004 to 2015 because when we started, we wanted to have at least 2-year follow-up. And so it took us much longer to establish this project. So this is why this data is a little bit older. So first data we could present at the EBMT meeting this year. It was accepted at the Presidential Symposium. It was presented by one of our colleagues, Karin, who is not here, from Gosh. So we developed a questionnaire to get more detail, and then that was available in the databases. It was sent out, and here you see where we focused on, and we had identified 663 eligible patients. Of course, some did not meet the inclusion criteria, and of course, not all of the centers responded, but still we had 314 questionnaires completed, and at the end we could evaluate 274 patients. So this is the patient characteristics. I won't go more in detail into those data because there is another presentation at our Presidential Symposium. We are happy that this has been accepted here as well, where there will be even more data than could be presented at the EBMT meeting. So just to say, median follow-up, the patients was 8.2 years, and survival was pretty good. So this is no longer the major problem. There were some late deaths, and as I said, more data will be presented at the main meeting, and regarding the type of the late effects and also correlations between disease condition before transplant, transplant procedures, and so on. And the paper is currently in preparation. So this is, of course, a work of many people. So here you see the table of all the representatives of the centers that have participated in this trial. And what do we think will be established with this? We want to guide post-transplant care, of course, and tell people what they should focus on. The question is, does it help us to prevent those late effects? And we are sure we will need more prospective data in the future.
Thank you so much for that update. Round of applause. We have time for 1 or 2 questions, and I will bring you the microphone if I can. I will open up by asking, the survival was 96%, which is really high. Is that because you're already starting, obviously, with patients that survived a certain amount of time, right? I just wanted to clarify that.
What was the question? Correct. Survival.
The survival that you showed of 96%, that's so high, I'm assuming, because you're starting from a certain time point.
Yeah,
Yes,
exactly.
right?
I think
just wanted
so.
to clarify that.
This is we choose this period because we knew that transplant procedures are different than the procedures before that time. So, yeah.
Very good.
Yeah, earlier diagnosis due to identification of the genetic defects and so on. I mean, there's many things that can't be compared in the years before 90 or something and now. So I think we have a cohort that has more or less, Anna Karin knows the data by heart. But
I just add that our eligible criteria was that you needed to have survived 2 years post-transplant. So many children die within that time period, and they were not eligible to be included in our study. So I think that's the main reason.
One more question, and that's it.
So maybe, I don't want to steal from the talk tomorrow, but I'm wondering, is there a way with these data to quantitate the neurologic impairment that the children have experienced?
I won't answer that.
Okay.
Wait for the talk tomorrow.
All right. Thank you very much.
Excellent. All right, and now I have the extreme pleasure of introducing our kind host, Jana Inge Henter, who will talk about the HLH Diagnostics Working Group results. So thank you, Jana Inge.
Thank you, Kim. So it's a pleasure to inform you about our journey towards improved diagnosis of FHL. So the background is that it's important to initiate HLH therapy promptly in FHL, and therefore early diagnosis is essential. The current criteria are based on expert opinion, so we think that they likely can be improved by more data-driven analysis. And the overall aim is to facilitate and improve clinical care and clinical trials for familial HLH. So note, this is for familial HLH. And we have like 3 approaches. We look for genetics, we look for functional analysis, or for clinical criteria. And we think that the diagnosis can be based on all of these 3 pathways: genetic data, functional data, and a combination of clinical and laboratory data. But when I say that the diagnosis can be made, it can be sufficient to start HLH therapy based on any of the pathways, but the diagnosis should be confirmed prior to transplant. So where are we? On genetic data, I will go into more detail later. We are working on definitions and refinement. Similarly, on the functional analysis, definitions and refinement. And then with regard to pathway 3, clinical and laboratory data, we are preparing diagnostic criteria and diagnostic score. And then we will look into those in more details. We're looking to 3 separate approaches, and we will compare them. I'll come back to that. So this is pathway number 1 on genetic diagnostic criteria. So we have some genetic observations that we think are sufficient for the FHL diagnosis, period. Then there are other genetic observations that can raise a suspicion of FHL, but then other diagnostic validation is necessary and functional analysis recommended. Then there are also genetic observations that could be undetermined or where the value is unknown. So this is basically the way we look at it. And then with regard to pathway number 2, on the revised functional diagnostic criteria, similarly, we have functional observations such as absent peripheral expression or defective lymphocytes exocytosis, and these raise a strong suspicion of FHL, but here genetic analysis is necessary, as we mentioned. Then you can have low expression or impaired exocytosis, suspicion of FHL, genetic analysis necessary, and repeated functional analysis recommended. And then normal findings, then FHL is less likely, but if there is a clinical suspicion, you need to do genetic analysis. Then the pathway number 3, what we call diagnostic score. Here we have a case-controlled study. So we have cases, and these are children in the HLH 94, HLH 2004 database with verified familial disease, and then a set of patients kindly provided from Italy. And with regard to controls, we have 3 control groups, and that is patients that have a clinical picture that is similar in one or another way to primary HLH. This includes systemic infections that could be confused with mass HLH or HLH, systemic autoimmune diseases such as juvenile idiopathic arthritis, and both of these cohorts are from a study provided by Dr. Angelo Ravelli and colleagues. And then more recently, we have also a cohort with severe sepsis at the pediatric ICU from Pittsburgh and Philadelphia, and patients with strictly defined inclusion criteria from Joe Carciello, Kate Kernan, and Scott Canna. And the method of analysis that we look at possible predictors, including a set of categorical and continuous predictors. We identify which of those that are important using logistic regression, compare cases and controls, and combine them to predict the FHL diagnosis. And here, again, we have 3 different options in this pathway that we want to compare. So one is using diagnostic criteria, the number of diagnostic criteria, such as 5 out of 8 criteria. Very easy to use, you use your fingers to count. The question is, how precise is it? Then as a second option, we can have a numerical score using cutoffs for continuous lab values. So for a specific lab value, you get some points, and if it's worse, you get more points, and then you add to a score, and you get a final score. That's a little bit more tricky to use. You need a calculator, but when again, we want to know how precise is this. And then the third option is numerical score using lab values on a continuous scale. So for each and every ferritin elevation, you get a little bit more of a score. And so this is tricky to use because you need a web page or an app, and then we are interested to know how precise is this. And then we will compare these 3 options and see which is the most easily used and how much more value does it give us. We have had some challenges. One is missing data in this data set. Another is that some predictors were initially missing, soluble CD25 and hemophagocytosis. This one is now solved because of the Pittsburgh cohort, and we're grateful for that. Hemophagocytosis is not solved because we don't have any control group with bone and marrow examinations, obviously. I want to show you in one slide about missing data and the multiple imputations so that you understand. So imputation is replacing missing data by substituted values. This means that we can preserve complete cases by replacing the missing data with an estimated value based on other available information. So here we have incomplete data. We impute data statistically, and we get a data set. We do that once again, and once again, we do that 20 times. So we get 20 new sets. Then we make 20 analysis of these imputed data, and then we pool those again, so we get a complete set, so we eliminate errors the best we can. And so I don't have any detailed results, but the genetic and functional diagnostic guidelines, we have a good progress. You've seen where we are. And then with regard to the clinical guidelines, preliminarily, we started to calculate on this quite recently, and it appears as if we can get quite strongly significant diagnostic criteria by all of these three methods. We need to recalculate and check and recalculate and check, but this is what it appears to be. And the strength of this is that we have some 400 patients with verified familial data that are the cases, genetically verified. So we have a strong golden standard for the cases. So data analysis are not complete, final results not available, but we're looking forward to getting those in a reasonable short future. I would like to thank my colleagues in the diagnostic working group, Mike Jordan, Anna Karin, Jenna, Elena, Kai, Jongmin, and Ashish, our statisticians, Julia, Ilahed Myrberg, and Professor Matteo Beutel, our Angelo Ravelli, Randy Krohn, Francesca for their cohort, Joe, Kate, and Scott for their cohort, and all contributors to these studies. Thank you for your attention.
Thank you, Inge. This presentation is open for 1 or 2 questions. We're doing good on time so far. I will ask the obvious question. Do you have any little hint of anything that you wanted to share?
I think it's too early to do that, and we would like to discuss that. But I thought I'd give you a little bit of a hint indicating that we have good results in all of those three. That's a tiny hint you would be given as of yet.
All right, fair. We'll have to wait. Such a tease. All right, well, with that, we'll say thank you, and we'll move on to Kai Lehmberg.
All righty. Let's see, Kai, we'll get you. Am I going the right way? Here we go. So, Kai, we're so pleased to have you speaking with us about the results of the HLH registry. Yeah, and there's a little button there, so if you need.
Okay, sorry. Thank you. I'll be very short because the meeting is very packed, and I would like to allow for more discussion maybe on other topics. So I would really like to give you an update on the current situation of the registry. However, I will not present the results of our interim analysis because they were accepted as a separate abstract. So this won't be part of today's presentation. As you know, the HLH registry is a joint project of the Histiocyte Society and the European Society of Immunodeficiencies. And these are the recruiting countries. And as you can see, it is not balanced with regard to countries. So there are some countries that have included more patients than others. I would like to give you an overview on the cohort that we have. So in case that you have any questions to the registry, so you're aware of what the cohort in the registry consists of, and so you might think of whether we can give you answers on the questions that you have. So I will skip this because this was part of the interim analysis, but the cohort of the familiar cases or of the hereditary cases of HLH is a usual distribution of genetic defects. So most of them are perforin deficient. A higher proportion is MUNC13-4 deficient, and the other defects are distributed as shown. So this is a rather usual distribution for Central Europe with families from different origins, and it reflects the most frequent population in the registry, which is in Central Europe. So most patients obviously had systemic HLH. There are a few with isolated CNS HLH, and almost a tenth are asymptomatic siblings. So when you feel that you have questions to this cohort in the registry, feel free to contact us whether we can answer your questions. With regard to treatment, just to give you an idea, most of the patients were treated at first line with etoposide, so with a classic therapy. And just a brief outlook on the results of the interim analysis. VP16 does better than you might have expected. So in comparison to the HLH 94 and 2004 studies, with current supportive treatment, the results have become a lot better. Okay, that's it.
Thank you, Kai. Don't run away yet. I have a question. Yeah. So Kai, I'm curious about the better responses to etoposide that you might be seeing in the registry compared to the clinical trials, and I wondered if that was related to some sort of reporting bias, or do you think it really is related to changes in supportive care? It's interesting, your comments.
I think it's supportive care, and it's probably speed of diagnosis. I think the diagnosis is made much more earlier than in the studies. So this is related to the fact that genetic defects are known and that functional testing is available that can speed up diagnosis of hereditary HLH.
Yep, so that's great, a real testimony to early diagnosis and early treatment, improving outcome. Any other questions? All right, we look forward to your next presentation on the same subject. All right. So I'll introduce Adi. How about that? Is that okay? So I'm very pleased to have Adi Zoref Lorenz, who will be speaking. She's from Israel, Sackler School of Medicine, and I'm really excited because as chair of the HLH steering committee, I've been wanting to mobilize an adult HLH working group for some time, and this year, we got lucky, and Adi and colleagues are beginning to form that group. So I asked her if she wouldn't mind coming today to just give us a glimpse into what they're talking about. They only formed literally a month or two ago, so it's early days, but thank you, Adi.
Thank you for this kind introduction, Kim. No, other way around. Okay, so I'm honored to present the project of our adult HLH working group. So you can see here there as first of all, our head, Gaurav Goyal, could not be here today, but he was very active in our meeting today. So we have a very distinguished members that have been investigating adult HLH for a long time. So familial HLH has been, patients with familial HLH, their prognosis have significantly improved over the last 2 decades because of research and discoveries made by a lot of people sitting here. But in contrast, the patients with malignancy-associated HLH, we do not know a lot about them. So we extrapolate the pathogenesis, diagnosis, treatment, but the outcomes are not so good. There's fewer than 20% long-term survival in these patients. So we defined that our aim as the adult HLH working group is to understand the biology and improve treatments for adults with malignancy-associated HLH. And I was, I was fortunate to publish this paper in Blood earlier this year under the mentorship of Mike Jordan with Joanne and other excellent collaborators worldwide. We gathered a series of above 200 patients to improve the diagnosis of patients with malignancy, and we discovered that the combined elevation of soluble CD25 and ferritin can facilitate the diagnosis of HLH. And when the group formed, they saw the paper and asked me to join, so I'm very fortunate. So a little bit about HLH and malignancy. So clinical data on HLH treatment in malignancy is very sparse and mostly comprised of single center experience or case report. And no studies have rigorously evaluated the lymphoma response and differentiated it from the HLH response, which is a very serious issue because patients with malignancies and HLH are treated, and it's very hard to interpret the data. And current strategy are mostly based on expert opinion, and the opinion is mostly commonly a two-step approach, which means you need to control the HLH and then treat the tumor. But we don't know what works better, what's the best approach. And novel agents are evolving like ruxolitinib and have become widely spread, and we do not really have good evidence to know how they perform in these patients. And so we try to summarize the current evidence for this review, and you can see in this table on the top, there are studies in etoposide in malignancy-associated HLH, and in the bottom, ruxolitinib in malignancy-associated HLH. And what is in common in all those studies is, first of all, the small n in all of them. And there is some studies reported the overall response rate, and some do respond to therapy, which again is hard to interpret because they do not really differentiate between lymphoma response and HLH response. But what is also in common is the really poor survival in these studies. So we understood that in order to understand how to best treat these patients, we need a substantial and very wide study. And the best way to tackle it is doing a retrospective multi-center study, gathering as much patients as we can. So that's what we're trying to do in the adult HLH working group. And we aim to describe HLH and lymphoma treatment responses in patients with malignancies, hematologic malignancies, and try to identify possible therapeutic strategies based on real-world data. So our primary objective is to determine factors predicting 180 days overall survival of patients that are either HLH 2004, and we also incorporated our new OHI index because we want to be inclusive as we can, and we saw that the OHI index identifies some patients that are currently not identified by HLH 2004 and also have very poor survival. And as secondary objectives, we want to determine the lymphoma response rate and the HLH response rate to different treatments, and to try to determine factors also predicting 30 days, 90 days, and 1 year overall survival. In terms of number of subjects, so we want as many as we can, and we would love that people from this audience or other collaborators will join this effort. We want to include patients that are either answering the HLH 2004 or the OHI index, which is soluble CD25 above 3,900 units per ml and ferritin above 1,000 nanograms per ml. And we initially said that we do not want to include children, but after our discussion again, we said that if we're doing such an extensive effort, we would love to include children, not for this main analysis of the adult HLH working group, but for future analysis, because maybe they even need this effort more because they're more rare and do not know what to do with these patients. So in terms of data items to be collected and reported, so we're gathering basic demographics, details regarding HLH initial presentation, HLH treatments and responses, and we will use the response criteria used in the bigimapalumab trial, data on the lymphoma-relevant international prognostic indices, which means the IPI for non-Hodgkin's lymphoma and the IPS for Hodgkin's lymphoma, again, the disease relevant per the patient, data on lymphoma-directed treatments and responses, and data on outcomes. So our next step is to submit, to rewrote the protocol, and we're finalizing it, and we'll be submitting it to the local IRBs where it's needed for sharing the identified data. We'll reach out to other centers and other people, such as yourself. And we made the data abstraction tool, and we want to change it into a REDCap platform, and the intention is to gather retrospective data, but some centers have expressed interest of gathering data prospectively, so we can then unify the data. A lot of people want tools to, so maybe this will be even an adult malignancy HLH registry. That's the start. And data collection, of course. So, and there are other future directions for our group, like biological differences between primary and HLH in the critical settings, and focusing on radiologic features of HLH versus other adult HLH patients. So this is my email. If someone wants to contact regarding the data abstraction tool to join our effort, we would love other collaborators.
Yeah, that's great. Thank you so much, Adi. We have time for one or two questions. Yeah, go ahead, Michelle. Or no, sorry, is that Michelle? Sorry.
We need CD25 staining on all those tumors because of all the diagnoses in your population. At least 20 to 40% of them are CD25 positive. So right there, it would impact that. The other practical problem, and it's happened at our institution, we now have switched from units per mil to picogram per mil for the SIBA-IL-2 receptor, and a lot of institutions have. And as far as I know, there's still no conversion factor. So just as a practical issue, so we've been using the confidence intervals on our new, assay, and we're hoping to switch back to units per mil because that's what most of our database is in. And then just third, I know that the German registry that was a prospective one was really active for a while. I don't know if it still is. That Paul and others originated. You could, that for EU members, you could enter in directly as you treat your patient. So just another thought. Yeah.
Thank you. Should I comment?
The microphone coming up to you.
Yes.
So, in collecting these data, there are many patients who will fulfill HLH 2004, just like many patients with lymphoma usually do. So, how will you differentiate that? You just have a patient with lymphoma who. No. Okay, there. Sorry. So how will you differentiate patients who fulfill HLH 2004 just because the criteria were so loose versus those who truly have hyperinflammatory? I know OHI is one way to do that, but how will you know that you're just not collecting all the lymphoma patients who just check the boxes anyway?
So I will answer both questions in the same time because both are great comments. So in terms of the fact that we do need more validation and the scale, so I think that gathering data from across the world with the exact units but your comment made me realize that we also need to collect the normal scale, especially for soluble CD25, will help us understand if it is valid and for Ashish in terms of how do we know it's HLH or not. So I think that if we will see what happened with these patients and how did they respond to either HLH-directed therapy or malignancy-directed therapy in their survival, then we can answer these questions. You don't think so? You're not persuaded at all. But I think that but part of our conclusion from the OHI work was that hyperinflammation in the context of cancer is something that is wider and we need to investigate it specifically. It's not familial HLH. That's the whole concept. This is not familial HLH, it's something else, and we need to gather a lot of data and to understand exactly what it is in order to treat it better.
Can I ask another question? Sure, okay. Because I agree with the Shis that it's very difficult, because as a pediatric oncologist, when you've got a large cell anaplastic lymphoma, which is typical HLH picture, you just treat the lymphoma. And together with Kim, we had the same approach. We did a study about HLH presentations in LCH. So what I think we may be able to contribute, but it's difficult for me. Because
it's difficult for everyone.
When do you call it now since HLH? Right. I think it's just the immune system going faster, and when do you say now it's in the red?
Right, so first of all, I would love to share a template of the data abstraction tool, because it's very, very detailed, because we're aware about all these complexities in these patients. So we have a lot of details about the treatments and the dates and when that starts and when the malignancy-directed and the HLH-directed therapy with peak lists. And we know that it's a challenge, and that's why we're having a lot of discussions to think about all these challenges and try to provide something that will help.
Great. Well, I'm very excited, and you know, it's not an easy question, Cor, but we've got the right team to work on it. So hopefully with everyone's help. So thank you so much. So now we're going to move on to speak about some of the recent work that relates to clinical trials, and I'm really excited to have Claudia Bracaglia here from Ospedale Pediatrico Bambino Gesù, who will speak on actually updates related to emapalumab trials. So I'm really excited about that.
Thank you. Thank you for inviting me to be here today. I'm a pediatric rheumatologist, so I'm not an hematologist and not an oncologist. Okay, so I'm going to present some data on the just completed emapalumab trials and the new one that is going on. Okay, so you know that MIS is a secondary form of HLH related to rheumatic disease, particularly to systemic juvenile idiopathic arthritis and other diseases like lupus. The role of interferon gamma overproduction in MIS and HLH is already known, so we know the relevance in the pathogenesis of the disease of interferon gamma, and emapalumab is a fully human interferon gamma monoclonal antibodies, and its efficacy has been already demonstrated in primary HLH, and the neutralization of interferon gamma has been also reported in some murine models. So I'm going to talk about these two trials. The first one is the NI 50106 trial that has just completed in a patient with MIS in the context of systemic JIA. And the second one is the Emerald study that just started, is ongoing, and is in a patient with MIS in the context of still disease, child and adult, and also in systemic lupus, both in children and adults. So regarding the first trials, so emapalumab is a pilot open-label single-arm multi-center study that in which were involved a center in Europe and in the US. Emapalumab was administered at the dose of 6 milligram per kilogram for the first administration, and then at the dose of 3 milligram per kilogram every 3 days for the first 2 weeks and every 2 days for the other 2 weeks. The treatment was for 28 days, and then the patient entered in the evaluation period until day 56, and then they enter in the long-term follow-up. So the patients enrolled in the study were 14, 11 in Europe and 3 in the US. All the patients received the diagnosis of systemic JIA, and all patients failed high-dose treatment with glucocorticoid. So here in the table you can see the clinical characteristic at onset, and some of patients were also treated with cyclosporinate and anakinra. So regarding the duration of treatment, 7 patients stopped the emapalumab treatment before the day 28 because they reached the clinical response to treatment, and 6 patients received emapalumab until day 28. Just 1 patient continued emapalumab after the first month and until day 38. So here in this picture, you can see the interferon gamma neutralization through the level of CXCL9. So as you can see, the CXCL9 is a chemokine directly induced by interferon gamma that can be measured in the serum of patients. So as you can see, all the patients demonstrated, presented a progressive reduction of CXCL9 levels during emapalumab treatment. So the mass remission at week 8 was the first efficacy outcome of the study, and was evaluated by the resolution of clinical sign and symptom of MAS, so with a visual analogic scale under 0.01, and normalization of the laboratory parameters of disease activity at onset. And during the study, 13 out of 14 of patients, so the majority of them, achieve MAS remission. Just 1 patient stopped emapalumab just after 3 doses because you reach the clinical remission after 3 doses of emapalumab. And 11 out of 14 patients achieve MAS remission at week 8. The 3 patients who did not achieve MAS remission reach the clinical remission of the disease, but they did not reach the normalization of white blood count, the first one, and LDH level, the second one. So here the glucocorticoid tapering over time. So as you can see, the majority of the patients receive a dose of 15.7 milligram per kilo of glucocorticoid at the beginning of the study, so in a week less 1, so before that emapalumab was started. And during 8 weeks of treatment, the median daily glucocorticoid dose was reduced until 0.56 milligram per kilogram. So all the patients tapering the glucocorticoid, and some of them withdraw the glucocorticoid treatment. Regarding the safety, no fatal adverse events were reported. All the patients were alive at the end of the study. No patient stopped the treatment during the trial for safety reason. 9 of them presented adverse events probably related to emapalumab treatment. 1 patient presented CMV reactivation that was controlled with antiviral treatment. And in the long-term follow-up, all the patients that entered in the long-term follow-up were alive at the end of the follow-up, and just 1 patient experienced HLH reactivation, MAS reactivation, but this happened 1 year after the emapalumab treatment was stopped, so the patient didn't have emapalumab in their blood anymore. So in conclusion, the trial demonstrated the efficacy of emapalumab in a patient with MAS, complicated systemic GIA who did not respond to high levels of glucocorticoid, and the treatment was safe. No severe adverse events were reported, and these results confirm the role of interferon gamma in the pathogenesis of the disease and the efficacy of the interferon gamma neutralization in this patient. So here the center who joined the study. So the Emerald study is just started. As I said, is for patients with MAS in the context of Still's disease and systemic lupus, children and adults. So these slides are property of SOBI. Is a 2-cohort, phase 2-3 open-label single-arm, is again a multi-center study. The design of the study is a little bit complicated because there is a run-in phase before the treatment in which patients with MAS can be treated with glucocorticoid dose, and but they are already eligible for the first screening. So after the run-in phase, if the patient did not respond to the high dose treatment of glucocorticoid, they can enter in the interventional phase. The scheme of the treatment is the same of the previous study, so 6 milligram per kilogram for the first dose, and then 3 milligram per kilogram every 3 days in the first 2 weeks, and then every two times per week in the other 2 weeks. And then there is a term of follow-up. The primary efficacy endpoint of the study is the complete response at week 8 after the treatment with emapalumab we started. The complete response is the normalization and clinical symptoms of MAS, and through the evaluation of the EVAS of the physician equal or under to 1, and normalization laboratory parameters relevant for MAS. And the secondary endpoints are the glucocorticoid tapering, dose lower than 50%, and glucocorticoid tapering to less than 1 milligram per kilogram of any time during the treatment, and time to first clinical response. And you can see all the secondary endpoints that are different. And a partial response that can be considered in the evaluation of patients is a resolution of improvement of the clinical manifestation, considering a visual scale below 4 point on 10 out of 10. And normalization of at least 3 of the abnormal baseline parameters of MAS activity. The safety endpoints are similar, incidence and severity of adverse event, number of patients withdrawn from the study, and there are also other endpoints regarding pharmacokinetics and pharmacodynamics. And again, just to say that all cohorts can be admitted in inclusion criteria in the running phase, and then they are divided based on the diagnosis for the treatment phase. And the exclusion criteria are similar of the first study, so primary HLH, diagnosis of primary HLH, malignancy, evidence of Leishmania infection and active mycobacteria and other intracellular infection, vaccination with live attenuated vaccine, and pregnancy and treatment with canakinumab, JAK inhibitors, CNF inhibitors, and tocilizumab. While anakinra can be used in those patients, but under the dose of 4 milligram per kilogram per day. And patients need to be not treated with a toposide in the month before they enter in the study. And thank you for your attention.
We have time for one question.
Might not be worthy of the one question, but there was one patient that had a relapse after 12 months. Do you know, did that patient get re-challenged with the drug, and if so, did they respond?
No, the patient relapsed after 12 months. That the treatment was stopped. It was triggered by ABV infection, but actually the disease was controlled with a slightly increase in a glucocorticoid dose, and the emapalumab was not administered again.
Okay, thank you.
I'm sure there are a lot more questions, and we can catch up with you later, Claudia. I would love to speak with you more about it. So now I have the great pleasure of introducing my colleague from St. Jude, Melissa Hines, who will be speaking about the HLH ruxolitinib trial that we have ongoing at our institution. So thank you, Melissa.
All right.
And what's with Melissa's slide? Oh, here. Yeah. We have a Swedish language here.
You know, I'm fluent in Swedish now.
There we go. Perfect. All right, my friend.
All right.
Oh, no.
No?
Sorry.
I am not very good with the touchpad, though.
I'm glad it is Rebecca and not I operating that little.
So this one is
PC
from
touchpad.
current slide.
Are we good? There we go. Okay.
All right. So I'm going to talk a little bit about HLH ruxo. And if any of you were in the June symposium that the Histiocyte Society did, some of this will be, you'll see it again, but hopefully there'll be some new data in here for you. So we do get funding for the trial from Insight. Here is the team. So obviously Kim is my co-study chair. Kristen is actually here, right there. And she is the study manager for the trial. So here are all of our sites. We have 10 sites that are actively recruiting inside the US. And you see they're all over the United States. So we came up with the idea of this trial because we know that hypercytokinemia is a huge issue in the setting of HLH. And so when you're thinking about new therapies for HLH, you obviously go down at that thought pathway. And so we know that interferon gamma is absolutely crucial in the pathophysiology of HLH, but in other murine models, it seems like there are other cytokines that are likely drivers for the pathophysiology of HLH. So one way to look at using new therapeutic approaches outside of etoposide is to inhibit interferon gamma itself. So this is what emapalumab does, and this is an excellent therapeutic approach, and obviously has been shown to have efficacy. But another way to do this is the use of JAK inhibition, so JAK1/2 inhibition, where you have inhibition of multiple cytokines all at the same time. So you're really just inhibiting the cytokine pathway. And in addition to just kind of broad cytokine inhibition, there also seems to be evidence of synergy with other HLH-directed therapies, namely dexamethasone, where in a murine model, and then also, it was also in a in vitro model, they gave ruxolitinib and dexamethasone, and the ruxolitinib actually resensitized the cells to dexamethasone-induced cell death. So there seems to be probably multiple mechanisms of action where this drug could be effective in the setting of HLH. So looking at our trial, this is kind of the building blocks of how this therapy works, is that obviously we always look for the trigger, treat the trigger for HLH. We give ruxolitinib, which seems to be likely synergistic with steroids based on the previous data that I just talked about. And so in addition to the steroids leading to T-cell apoptosis or ablation, you also, if the patient needs it, you can use etoposide for additional T-cell ablation. The central trial objectives are that we wanted to repurpose ruxolitinib for the treatment of HLH, both in the setting of frontline patients and in salvage patients. And we also wanted to look at the idea of a response-adapted therapy for HLH. The other things we were going to look at would be time to response, time to transplant, long-term outcomes. So we are following these patients out for 1 year after they start treatment with ruxolitinib. Response adaptive regimen, and then also looking at ruxolitinib pharmacokinetics in this setting because it's a younger patient population and it's also not really known what the pharmacokinetics are going to do in the setting of hyperinflammation. So like I said, our trial design, we do have a frontline arm, so patients that have never been treated before can go onto the frontline arm, and then we have a salvage arm for patients that have previously received therapy. And the frontline arm is actually broken up into 2 different parts. There's a safety phase and an expansion phase, and I'll go through the difference of that here in a little bit. But the frontline arm is more like a phase 1B, and then the frontline and expansion arms are phase 2 trials. Our inclusion criteria is we are looking for pediatric patients and young adult patients that have evidence of active disease, and then patients that are going to go on the salvage arm must have failed previous standard of care therapy, so etoposide-based therapy and ATG or ATG-based therapy. Our exclusion criteria, we are not putting isolated CNS disease patients on there because that's just a whole nother Pandora's box. Also malignancy because of all the things that have been previously discussed, and then rheumatologic disorders are also excluded. So we're not including MAS patients. So just to give you an idea of what this therapy looks like, so for the frontline safety phase, if I remind you, is the phase 1B part of the trial, where patients are actually being started on all 3 drugs up front. So they're receiving etoposide, ruxolitinib, and dexamethasone, with dexamethasone weaning over the 8 weeks of therapy. And so that's very similar to HLH 94-2004. The big difference with the etoposide piece is that we are only giving 1 dose per week, and if the patient receives a reasonable response at the end of 4 weeks, then you can actually stop further etoposide dosing and continue etoposide and ruxolitinib alone. I do want to note that the ruxolitinib dose that we're using in this trial is about 3 times higher than what's been previously published by other groups that have used ruxolitinib in the setting of HLH. So the frontline expansion phase in the salvage arm, these patients are actually only started on ruxolitinib and dexamethasone up front, and then etoposide is only added if they do not respond to that therapy by study day 8. And again, if they receive a reasonable response by 4 weeks, then further etoposide doses can be held. So there's a potential that these patients, if started on etoposide, will only receive 3 doses. And then there's a potential for the frontline safety patients to only receive 4 doses of etoposide if they are doing well. So overall, what we're looking for is that there are obviously some patients that are going to need etoposide-based therapy just because of the severity of their disease, but overall, we are hoping to reduce the amount of etoposide these patients are seeing. So far, we have 4 patients enrolled on the frontline arm. We have 2 patients on the salvage arm, and we initially could not enroll patients less than 6 months of age because of concerns from the FDA. We are now enrolling patients less than 6 months of age onto the trial. Just to give you a little tidbit about what we're seeing as far as adverse events in our patients that we've had so far. Overall, the patients have done well. The regimen has been really well tolerated, and we have not had any dose-limiting toxicities. We've only had 2 serious adverse events that were actually unattributable and that were not attributed to the regimen itself. As far as what kind of adverse events we've been seeing, most of what we've been seeing are transaminitis, but those patients that have had transaminitis, it hasn't been persistent, and they've had no synthetic dysfunction. We've been seeing a lot of issues with high cholesterol and high triglycerides, and that's typically occurring later in therapy, so 6 to 8 weeks after they've started the ruxolitinib. We've had pretty minimal infection, only 2 infections reported in the patient so far, and only 1 attributed to the regimen, which was a CMV reactivation. And then obviously we've seen a lot of cytopenias that have not required any study drug interruption. So that is all I have.
Thank you very much. And we do have time for a few questions with this presentation. I will open it up. I have a very just curiosity question. Where are your patients coming from around the US or even outside the US?
All over. We've had some in Memphis, lots in California. California apparently is the place to be for HLH.
Very good.
Wisconsin.
Mike?
Just a super simple question. Can you remind us how many patients in the first run-in phase?
So the run-in phase, that's a good question. So at least 6. Yeah.
At least 6.
It depends on the DLTs. So if there are no DLTs, then we only need 6. It's like a 3x3. Does that make sense? Okay.
Yeah, and actually it's an interesting question that you bring up, Mike, because Melissa and I have been speaking. So now as more and more reports have come out in the literature on the use of ruxolitinib, we are finding that the PIs, the site PIs for the studies and the families are a little reluctant to potentially enroll on the safety phase because it involves etoposide up front. A lot of people want to try the ruxo-dexa combination with addition of etoposide only if needed. So we're actually going to go back to the IRB perhaps to request to terminate the safety phase early and move to the expansion phase, because I think there's plenty of data in the literature now that the combination of ruxo and dexa is safe and effective. And, I mean, this is the Chinese paper that was just published. And even though there was the Chinese paper, I mean, I think our study has the potential to offer a lot more. Higher dose given with dexa, primary patients, infants, none of those were, really, those factors were part of the Chinese trial. And then we also have really rigorous biology studies collecting, blood, bone marrow, and CSF very regularly throughout the 8-week period. And we'll be doing, pharmacokinetics, immunophenotyping, serum plasma profiling, and single-cell sequencing. So I think we're really hoping to look at biologic responses and predictors of response. So that's the story. Cool. All right, thank you, Melissa. Oh, one more, way up there, go ahead.
A brief question about platelet levels. Do you have a platelet threshold? In adults with myelofibrosis, there's typically a platelet threshold of around 50, which would not be very useful in this population. So that's a question, and also other JAK inhibitors with a similar efficacy profile do not usually diminish the platelet levels. So perhaps this could be an advantage to other continents recruiting a lot of patients faster if you could use other JAK inhibitors.
So to the first question, as far as platelets, I mean, all of our patients are cytopenic, and so it's not been inhibitory, and we don't have a threshold that we require them to give ruxolitinib. As far as the use of other JAK inhibitors, that's a question that hasn't been fully elucidated yet, because we don't know how much of the effect we're seeing with ruxolitinib is if it's due to the JAK1 and 2 inhibition or just the JAK1 inhibition. And I believe that Kim is actually doing some preclinical data looking at, head-to-head JAK1 inhibition and JAK1, 2 inhibition.
More to follow.
Yes.
Do we have time, Rebecca, or do we need to move on?
We should probably move.
Okay, we'll
I don't know, you're at the clock. How's the clock?
I don't even know. The phone is reverted back to, yeah, we'll probably move on. Melissa. I call Rebecca and Melissa, again, I'm confused in my old age.
I'm not sad about that.
All right, so we will move on to our next speaker, which will be Despina from Necker-Ahon Malade University Hospital, speaking on updates on alemtuzumab. Thank you, Despina.
Thank you for letting me just summarize. So I didn't prepare slides. I don't know who has been in the morning session. So we have completed the prospective trial since a while, and we continue to follow this strategy without having a formal trial ongoing. So it's all patients in France essentially will be followed up by alemtuzumab. But and we are still happy. So just to resume in 2 words for those who have not been here in the morning, we arrive at about 92% of patients that survive until transplantation, and without a significant infectious complication, which is always the fear of this kind of protocol. And just to follow up also with regard to the 2 words about the ruxolitinib study, because we are now in the very end of having a study approved, so it's already gone through the French FDA, let's see, and we are just finalizing the very last hurdles that you always have in a clinical study. So we are pretty nervous because we have these very nice results on alemtuzumab, and contrary to the American approach, we will not associate toposet. So we will go for ruxolitinib in a high dose together with methylprednisolone because we are more used to this. And, well, we see. We didn't have a pilot phase, so it's really starting from zero to this new drug. We therefore do a 2-phase study where the first 6 patients will be treated in our unit so that we have them really on control, because the risk is always that you somehow don't know if it will be efficient enough or if you need to leave the protocol. And so we prefer to do this in our unit, and if the results are positive, so that we don't that we are not less effective than with the CAMPAS, then we will extend the study to all France, I mean the most important centers. And as Kim, we will not do neurological only in the first place, because we don't know if this drug really helps us enough to be as efficient as we have been with the alemtuzumab study. So there will be a phase of double approach in France as soon as we start the study. We did not write specifically that we don't go for very young children, but FDA, so the ANSM in France, asked us to not include in the first 6 patients the very small ones. So we will see how things will be going and adapt the results and then enlarge to a broader inclusion. So this is about the situation in France with regard to primary HLH. And so I think, yeah, thank you.
Yeah, no, I think it will be really interesting to see what happens with, you know, the combination. You have such nice results with the alemtuzumab, and I think, you know, there might be differential responses to the combo of Ruxo and Dexa depending on how severe, you know, children are when they present. And, you know, we won't know until we try it, and so you'll see. I guess my question would be, in patients who you have in that early 6-patient phase who aren't responding quite as you'd like, would you give alemtuzumab at that point, or, yeah, because you don't prefer the etoposide?
I think we will go to alemtuzumab in any case, especially for the primary ones. And it's true that we are very happy on the results of alemtuzumab, but as everybody in this audience knows, alemtuzumab is not freely available for this indication on the market. The company will withdraw alemtuzumab because they wanted to make more profit on multiple sclerosis. They changed the dosage from 30 milligram to 12 milligram in one vial, and the price went up 30 times per milligram. So this is enormous. For the moment, we get it for free, but we need to have authorization, at least in France. I don't know if it's like this in other countries. So we felt that even if we are very pleased with our results, there are a lot of countries that have no access to alemtuzumab, and we don't know for the future if we, even in France, will have access to this drug forever. And so this is why we try to develop in a clean clinical setting, prospectively, new approaches to see if we can, maybe there will be maybe different indications for the very severe ones, the less severe ones, the older ones, the younger ones, who knows, but we need to go on and check it out to have alternative approaches for this rare disease. I think this is the important thing.
So for the alemtuzumab, I'm trying to remember, do you all dose by level, or?
No, in the prospective study, we just gave a very strict protocol with defined dosage at different time points. Our hope is that in the future, maybe we'll have some help with pharmacokinetics. So we are currently developing pharmacokinetical models to give predictions, so that maybe on day 3 after the injection, you then can say, okay, this kid didn't have enough for his activation, and we can then complete it. But for the moment, it was clinical and biological responses at different time points, where we then added on other courses of alemtuzumab.
And then one other question. It was about, so with alemtuzumab having the bad reputation in the past for having a lot of associated infection, do you think that based on your experience with it, using it as a frontline, a lot of times when we were seeing really bad infections, it was because we had heavily pre-treated patients before we used the alemtuzumab, because in that setting we were using it more as a salvage agent?
Yeah, I think this is the key point. If you have a diagnosis that is fast, and we all count on Jan Inge to help us with this, with his studies, and you go very quickly to treatment, then you go quickly also to hematopoietic stem cell transplantation, we virtually don't have more infectious problems than for other approaches and other transplants we do in inborn errors of immune system. So I think it's a question of duration and yeah.
All right, are we good? All right, I think we'll move on to the next. Thank you so much, Despina. Now I have the distinct pleasure. Clap, clap, clap. There you go. you can leave it. Of introducing my co-host, Ms. Rebecca Marsh, who will speak on updates on tadakinig alpha.
Thank you, Kim. And I just set my own timer, so I'm not giving myself any extra leeway compared to everyone else. So yeah, I'm actually presenting really today on behalf of Ed Behrens, who couldn't be here today, but I'm gonna talk about the tadakinig alpha trial for patients with NLRC4 mutations and XIP deficiency. So you guys will remember that XIP deficiency results in dysregulated TNF alpha receptor signaling and function and results in NLRP3 inflammasome overactivity. And you will also recall that pathogenic variants in NLRC4 are, in essence, gain-of-function activating mutations, which result in constitutively active NLRC4 inflammasome function. And these inflammasomes basically are responsible for processing and activating pro-IL-1 beta and pro-IL-18. So patients with these disorders are making lots of these proteins all the time, including lots of IL-18, which, recall, can synergize with IL-12 or IL-15 and result in interferon gamma production and propensity to develop HLH. Now, what is tadakinig alpha? Tadakinig alpha is a recombinant human IL-18 binding protein. Who here makes IL-18 binding protein in your body? Everybody. So we all have it. This is a recombinant form. So we're just giving something that you are making all the time anyway. Most IL-18 in your body is bound to IL-18 binding protein, is inactive, but in patients with XIP deficiency, NLRC4 disease, also patients with systemic JIA who are prone to MAS, etc., these patients have so much IL-18 that you'll see in the middle of the figure that they have excess free IL-18 compared to patients with autoinflammatory disorders or primary familial HLH disorders that really have enough IL-18 binding protein to even be soaking up those mildly elevated levels of IL-18 that happens with HLH in those settings. So I don't have any data to share with you from the trial, but I will just point you to two publications that are in the literature, including Ed and Scott's case of a patient that was treated on a compassionate use basis with tadakinig alpha for treatment of NLRC4 disease. And what you can see here is a picture of the patient on the left. You can see that at the red line with the start of treatment, CRP fell, ferritin fell, oral intake improved. The one on the bottom, I know you can't see it, I'm sorry, but what you can see on the left of the line is there are lots of other drugs, including steroids and cyclosporin, anakinra, et cetera. And on the right of the line, most of those things go away except for a patient was continued on infliximab. And then on the right, you can see relevant things like CXCL9 levels of free IL-18, which plummeted, and total IL-18 levels. Similar case report published by Ashley Geerlings, who did a one-year immune deficiency fellowship with us. And you can see this is a patient, this is actually Mike Jordan's patient with XIP deficiency. And what you can see is that this patient was treated on study with recombinant human IL-18 binding protein, but has also received it on and off on a compassionate use basis. And you can see, there's grayed out areas for study time, but you'll notice that after came off study, reflared, was started on more medications, was restarted on tadakinig alpha, and you can see things like the IL-18 and ferritin and CXCL9 that had gone up, sort of immediately fall down to within normal ranges again. So there is a phase 3 clinical trial open, as most of you are aware. The drug is made by AB2 Bio. This is a multi-center, double-blind, placebo-controlled randomized withdrawal trial with tadakinig alpha in patients with these two disorders, and it's followed by an open-label extension study that patients can enroll on. And it's important to note, most people don't quite get it the first time around, but there is a single-arm open-label treatment period, and what's randomized is the withdrawal period. So at randomization, 50% of patients keep getting tadakinig, 50% of patients come off, and that's where we're testing efficacy for those patients. These are the inclusion criteria that you can see here, just in case you have any patients. I will cheerlead a little bit for this study because there's only one more patient needed, and then they will have the data after that patient hopefully completes study to then potentially talk with the FDA about seeking approval and this sort of thing. But inclusion criteria include a ferritin greater than 500 or CRP more than 2 times the upper limit of normal. and what's called a modified autoinflammatory disease activity index, and you can see it on here, and it basically includes things like fever, nausea, vomiting, diarrhea, signs of inflammatory bowel disease, organomegaly, also uveitis, arthralgia, arthritis. Some of the XIP patients do look more like a systemic JIA sometimes, and also, of course, cytopenias. This is where the study is open, so if you do have any patients you're interested to discuss, please call your local friendly rheumatologist, immunologist, or hem-onc physician who's involved in the study. And like I said, we only need one more patient to complete the study, so cheer, cheer for trying to get this through, because I will say it does seem to be very effective for some of the patients. And with that, I'd be happy to take just a couple questions.
Any questions for Rebecca?
Melissa.
Oh, here we go, Melissa. I'll run up to you.
It's actually hard to go up these stairs because you're so paranoid about falling in front of everyone.
So do you know, is there any plan to start anything for the systemic JAA patients?
That was my question.
Because I've had a patient that I want to put on this drug so bad.
Yes.
But they don't have the mutation.
Yeah, those discussions are ongoing, but I honestly do not know where things stand. You could ask Ed. Yeah, I'm sorry. I should have prepped that question ahead of time.
We'll bother Ed.
Yeah, I was going to ask the same question because IL-18 is such a key upstream driver of interferon gamma and mediating disease. I was going to say the same thing. Anybody else? No, we can't wait to hear the results.
All right, me either. And there's at least one patient with systemic JIA and also interstitial lung disease that's been treated compassionate use with tadakinib. That seems very responsive. He actually just anecdotally was just geared up to go to transplant 3 weeks ago. Came off drug, but then popped up with an infection right when we were starting conditioning, and so got treated for 2 or 3 weeks. And during that time off of tadakinib, like immediately flared again. So it does seem to prevent for these types of patients, and it makes sense physiologically. There are also IL-18 monoclonal antibody coming down the road and other treatments. There's an IL-1 and IL-18 trial open. Is that Novartis? I can't remember, Mike. Novartis? Yeah. All right, I'm also going to talk very quickly about an update on an NIH consensus effort that Rafaela Goldbach-Monsky and Scott Canna led. And again, I'm also sort of presenting on behalf of them, as well as Bita Shakori, Fabrizio De Benedetti, and other folks. Basically, some of you in the audience are familiar with this project. But I'm just going to give a very brief highlight. There will be a lot of tables I'm going to zoom through super fast. They are here just to make the point of what we've done. If anyone is really interested to really look at them, I'm happy to look at them afterwards with you, or like even email them to you potentially. But this is the group of folks that have been involved with this effort. And really, the effort was to develop consensus statements to help basic clinicians. So, general hospitalists, maybe even ER physicians, but people at the smaller community types of hospitals that are seeing these patients very early. So not when they're coming to us at the tertiary care centers and we're all debating which therapies to use, but the poor hospitalist who's taking care of some sick patient in their, mid-sized community hospital, this type of thing. And you can judge whether or not, we sort of stuck to that goal. But we really aim to develop evidence and consensus-based guidance to assist clinicians in optimizing decision-making in the earliest stages of diagnosis, treatment, and monitoring of HLH or MAS. Methods, really, this was a multinational, multidisciplinary task force that was convened. We met face-to-face in August 2019 at the NIH, pre-COVID. During COVID, we did a lot of things remotely, and there were 2 rounds of questionnaires that were circulated to develop consensus statements addressing early identification, diagnosis, and monitoring of HLH and MAS. Then in March and April of 2021, we had consensus meetings virtually. Basically, we voted and discussed statements that had been developed over the last year or 2. Statements that achieved at least 80% agreement were accepted. Oxford levels of evidence and grade of recommendation were assigned, and things like this. So results, we developed 6 overarching principles, 24 specific points to consider relevant to the goals here. Again, due to time, I'm not going to go through these things, but I do want to just highlight a few things. So for instance, some of our statements evolved and revolved around how do you recognize HLH. So you'll see many of the familiar criteria that we all use to assess and diagnose HLH, along with a few other things like CRP, LDH. We actually put liver enzymes into this, etc. We talk about checking serial ferritins. Everyone should have serial ferritin testing if you're still suspicious of HLH. Some of the things that we include, of course, evaluating for underlying diagnoses. So being very specific about you need to be figuring out what your patient with HLH has underlying. We have a few statements about CNS involvement. We have some statements about treatment. So this was not meant to rehash, oh, give a topicide, do this, do that. We really wanted to just give that poor hospitalist at 2 a.m. some sort of guidance what that they can use to treat their patient safely. And so we did make a statement recommendation that initial therapy could include IVIG, anakinra, and high-dose glucocorticoids. With the caveat, of course, you ideally want to get your malignancy evaluations completed before steroid therapy. And that's really all I'm going to say about that. You can see the rest of the statements here. Obviously, if anyone's really interested, I'm happy to talk to you. We also tried to make some sort of practical flow charts addressing the very early stages of treatment for these patients, what to check for, and then really going on to specific types of therapy depending on underlying indication and in consultation with experts in HLH. Practical fun things we're trying to do is make these little asterisks link to actual other documents like the Histiocyte Society, consensus guidance on etoposide use and things like this. And with that, I'm just going to say thank you. The manuscript draft has been completed. It's been reviewed by all task force members, and the current step is Scott submitting to the ACR and EULAR executive committees, and we will see how that goes. There's also a separate methods and systemic literature review that BETA and ERCAN are actually working on. So thank you. And thank you to all of you that participated. We could not have done it with all of you that were involved in this process.
Do we have any questions for Rebecca? Yes, go ahead. I'll come up.
Yeah, so there's language in the text surrounding this very issue that really you want to be getting your malignancy evaluations first. But we do include it in the table because as we all know, sometimes there is a critically ill patient that just something needs to be done, before they die, and you actually get those. But in the text, we really address that.
Yeah, I have a question for you. So this is aimed towards these physicians in rural areas or smaller hospitals under-resourced, but it's going to be published in rheumatology journals. So how the heck are we going to get this information to the right people?
Yeah, Mike also has this question. And I can take this question and thought back to the sort of steering committee again, because we have discussed this. This effort was initiated in parallel with 2 other efforts in autoinflammatory disease and that have been published in the rheumatology journals, and the intent was always to publish those in those journals because this was EULAR and ACR sponsored, and so for those reasons it's probably still going to end up in a rheumatology journal. But I hear you. I do not disagree. Yes.
Yeah, we need to figure out how to get them disseminated in the right mechanism.
Here, wait for the microphone. Sorry. That way everybody can hear. Can you read?
There's just for everyone to know, because it's a great one to pass along. It's called emcrit.org, and a lot of the community docs, at least in the U.S., go to it when they have an ill patient. Now, it might not just be the persistently febrile. They've got a very good section on MAS and HLH, very practical. So
that's amazing.
If at least if your guide could be referenced in that.
No, we can certainly put that in. It's EM, like emergency medicine, crit, critical care. EMCrit. I'll text that to myself right now so I don't forget.
Sure, I can send it to you.
That's why these meetings are so fantastic.
Yes, for sure.
I would not
Thank
know
you.
about that. Thank you. Whoopsie.
All right, we will move on. So it's my great pleasure to introduce the man who needs no introduction, but next we will hear from Dr. Mike Jordan about the Into HLH registry.
Thank you. So I think we're moving on to non-trial things going on. So yeah, I want to tell you about this registry that we're just starting called the Into HLH Registry, the Insights into the Natural History and Treatment Outcomes of HLH. And so I've been working on this with the support and help of SOBI. Carl Allen has also been involved. And for those who know him, he's the person who needs no introduction in Castleman's disease. David Feigenbaum, as well as Adi, has been absolutely essential to move this forward. So I think the question that probably maybe the unspoken question, why another HLH registry, right? So we already have the HS registry, which is a very fair question. And there's also an adult, there's one for adults, and there's various other national or otherwise focused registries for patients with HLH. But in brief, I think what it's fair to state is that the detailed natural history data on patients receiving therapy, it really remains quite sparse in literature. The Novimmune trials are really the only ones that reported response data with any kind of precisely defined response criteria that were, with complete data. I should say trial, not trials. So really it's quite sparse in the literature. And so we recognize that. And this is something that was really obvious when talking to regulatory authorities about actually getting a new drug approved for HLH is, well, what do you compare it to, right? Because there is the literature is just so sparse. And so this gap is even more prominent for non-familial forms of HLH. And so while the HS registry has its value, certainly, I think it's important to note that it wasn't intended to fill this kind of gap of deriving sort of detailed natural history data on patients. It was intended as sort of a lean registry, I think that's Stefan's word, to make it easy for many, many sites around the world to participate in. It was originally intended as sort of practice for an international treatment trial, so it didn't really have this sort of outcome in mind. And it's also, of course, intended to be limited to primary HLH. So the Into HLH registry, so the aim, I think, is already should be obvious to you, is to really assess a detailed natural history, describe clinical etiologic diversity, complications, and treatment outcomes in patients with HLH. So there's lots of things we don't know, like how often do they go to the ICU of this and that organ failure and so on and so forth. So the primary objective reflects that. The secondary objectives are all listed there, and they are, I think, related to that. I won't read them all out to you. So I'm going to move on. 1, 2, 3. Yeah. All right. So just a little visual sort of framework to understand how this is going to work. So it starts with the patients, of course. All right. And so we have a website in which patients can be consented, or they can actually e-consent into this registry right now. And they also give us permission to obtain their medical records. So we actually go straight to the source, to their hospitals, and retrieve their medical records. And we abstract those into the HLH database. Now, what about physicians, right? So, these sorts of patients that we enroll will oftentimes, as you might imagine, be in retrospect. So many patients that are busy with consumed with a new diagnosis are not going to be enrolling on this. And so there's a real need to try to gather data more contemporaneously from these patients, and also to try to gather biologic specimens while they're just diagnosed or on therapy. And so for that, we're planning to partner with Nacho. So we're working out the details of how we'll do that. But Nacho already has sort of an omnibus sharing protocol called Nacho Bio that's open at many of the Nacho centers in North America. And so we are planning a formal sort of collaboration to allow, sort of expand Nacho Bio to allow the sort of the registry activities to occur in tandem with Nacho Bio. And that'll allow sort of concurrent collection of biologic specimens. We'll also be able to gather data directly from the physicians to understand in more detail sort of their decision-making, medical decision-making sort of information. And then, of course, the medical records as well. And all of this is overseen by a steering committee. SOBI is providing us with support and funding to conduct this. And the outputs, of course, the data will go into the database, and the outputs would, of course, include publication. One of our goals is that we can also, by providing some funding for many sites in the U.S. to participate, we think we can greatly increase the number of U.S. patients in which registry data is collected. We'd be happy to contribute that to the HS registry, because I know the U.S. is sort of lagging because of the funding issue. And then SOBI would like to utilize some of these data for filing with regulatory authorities. studies, because this really allows us to gather, and we're gathering data about all patients. We don't care whether they're treated with emapalumab or not, but this would allow there to be a sort of a fair description of what really sort of happens in terms of response to therapy and complications and so forth in patients, regardless of how they're treated. And so we call these two things either the patient-powered arm, because it's really driven by patients and recruitment of patients. They sort of can enroll themselves, or the sort of the more conventional physician-driven arm, that is that physicians can actually recruit the patients. So the advantages is that, of course, we'll get very detailed data. This will allow very high-quality assessment of patient outcomes, responses, adverse effects, and events, things that really haven't been described in this patient population. We'll fill in these knowledge gaps. These complete medical records will allow us to adjudicate kind of critical questions by expert review panels, sort of the questions that we wrestle with, but we don't really know the answers to often. Limitations, of course, is that these medical records have to be in English, because we don't have the capability of abstracting from non-English records. And as the British say, we don't really speak British English. But in all seriousness, it's such a different system. It's too ambitious for us to try to pull in records from other English-speaking countries. So the registry is limited to North America, which technically really is USA and Canada. And of course, this extraction, since it's laborious, takes time. So, but I thought a few other points here just bring up is that, what can we hopefully address with a really detailed registry that we can't address right now? Well, this question of delayed or missing diagnoses, by the way, how's my time? Okay, cool, that's good. So these are just a few thoughts to throw out there. Like, what's the value of having a more detailed registry, right? We don't really know what the true incidence of these things are. So we know the registry, the HS registry, is measuring time from onset to treatment, but this is really only a guess, right? There's lots of things that could impinge upon that. But could we really describe the details of kinetics of disease onset? And I think the answer is yes, because we will have really detailed data on these patients. We recognize there's some limitations, right? Patients that have a truly misdiagnosis and, say, pass away may be missed in this registry. But I think that we'll be able to get closer to this answer than we've been able to so far. What about this idea of wrong diagnosis, right? Just because somebody has a diagnosis of HLH doesn't mean we'd all agree with it. I think we've all seen reviews in second opinions where we might actually have real concerns about that, right? So this is a perhaps controversial question, a tricky one, and I think the only way to really address this systematically is to look at detailed patient records. Response to therapy, again, real detailed response data in a real world setting are quite lacking. And yes, we can, of course, really do a lot more here. And of course, adverse events. We don't really know the frequency of adverse events in this patient population. We all know they have a lot of them, but the only example, I think, is really the Novimmune trial. So anyhow, so this is the web address. Thanks for listening. Spread the word, tell your patients, and at least if you're in North America, I would say, please participate. I'd be happy to discuss further with you. Thanks.
Thank you very much. This presentation is open for a couple of questions. We have 2 minutes. Okay, I'm coming.
Thank you for pointing that out. Yes. Short answer, yes. Okay. We are, I know Rebecca worked so hard running up there. So, so we are, my focus has kind of been on, let's start with, what we know most about, sort of the primary HLH patients. But the short answer is yes, we would like to include all kinds of HLH. And so the efforts will be, ongoing, I would say, to try to start including more of every kind of HLH out there. As I already pointed out, there are other registries, so we need to collaborate, I think, for instance, with adult registries and so forth. But, yeah.
Mike, is SOBI providing funding for us if we open it globally?
Yes.
And we gonna abstract the chart and just put it directly into the database? Or are we supposed to send the medical record to Cincinnati?
So we will get the record and abstract it like we do with the ones that come in through the patient powered arm.
But we would consent and we would have the study open locally?
Yes, yeah. So it's actually going to be through Nacho Bio. So to be clear, right? So it's going to be through Nacho Bio, and we're working with Texas Children IRB about how to make this work. So this would be essentially a rider on the current Nacho Bio contract. So if you're a bio site, right, then you can accept that rider, and then you can it'll provide funding actually to enroll, gather biologic specimens, and provide the data that you'll provide. But we will access the records with the same mechanism that we do with the patient-powered arm. So so you won't be opening the registry locally. It'll be an amended version of Bio with an explicit sort of opt-in for patients that are potentially eligible for this registry.
I think the problem is going to be the legal issues. Like UCSF will not allow a release of a whole medical record. I think yours is the same.
Yeah. Then we should discuss UCSF, yeah. Yeah, the other way around it, I mean, the other simple way, if there's an institution such as yours that wouldn't be agreeable to that, is that if the family is interested, of course, then we could allow them to simply e-consent through our patient-powered arm, right? That may or may not be problematic in terms of us providing support to your site, but you know, I mean, that's certainly a way to enroll them.
All right, thank you very much, Mike.
All righty, you guys are doing great, holding out till the bitter end here. We're going to move on to our next presentation. We're bringing Claudia back down, and she'll be talking about ongoing HLH MAS initiatives in the European Pediatric Rheumatology Society. Here you go, Claudia. Thank you.
Okay, thank you again. Oh, sorry. No.
You have to use, here, sorry, I forgot. For these,
Yeah.
you need to use this one.
Okay.
I'll get it up and running for you.
Okay, so I'm going to present some of the activities that in the Mass SGA Working Party of Pediatric Rheumatology European Society we are going on. No, it doesn't work. Yeah, it's okay. Okay, so here the core team of the Mass SGA Working Party. So actually we have around 80 press members who participate to the Mass SGA Working Party activities, and we have an annual meeting during the press congress that will be have in the next days. So the aim of the Working Party is to promote knowledge and collaboration, international collaboration among the experts in the fields of Mass and SGA, and to foster translational research in order to improve the care of those patients. So I'm going to present briefly some two projects that we have just concluded. So the first one is a project aimed to build a risk score of MAS in patients with systemic GIA. So we collected data from patients with systemic GIA with or without history of MAS, and we have tried to build a score that can help clinicians to identify patients with high score with high risk to develop MAS during disease course. So first we collect patients with systemic GIA. Some of them were excluded at the beginning of the study because they have already MAS at time of sampling. We then identify 69 patients with systemic GIA, 41 of them without MAS, history of MAS, and 28 with at least one episode of MAS. We then look at laboratory parameters, and we found that ferritin, LDH, AST, and triglyceride were significantly different in patients with or without history of MAS. So we use this parameter in order to identify a cutoff of each parameter that can help to distinguish patients with risk or not to develop MAS, and we built a score with this cutoff, and we assign an arbitrary number of each parameters until we identify a risk score with a high specificity and sensitivity to identify patients with systemic GIA that can develop MAS. We then tried to validate the score in a different population, so we collected data through the Mass SGA Working Party from other Pediatric European Rheumatology Center and also from patients from Canada, and we applied this score to those patients. So as you can see, the specificity was lower compared to the initial score, but the sensitivity was still high. And this is important because the aim of the score is to avoid to lose patients that can develop MAS. So it's not a diagnosis score, it's just a score that can help clinicians all over the world because it's just characterized by simple laboratory parameters that everyone can perform in his lab to pay more attention to those patients that probably can develop MAS. So this is another recent project that we have just concluded, and this project was started based on a recent publication of Michael Jordan group in which identify T cells that can help to distinguish patients with primary HLH from patients with early sepsis. So we have tried to evaluate this population of this cell population in our patients with secondary HLH in the context of systemic GIA, but also from other triggers and systemic GIA patients without MAS, and actually we found that the CD38 positive T cells can distinguish very clearly patients with MAS and secondary HLH from those with systemic GIA without MAS. And in the context of these cells, we identify another population, the CD4, CD8 positive T cells that are significant increase in patients with all form of secondary HLH, and again can distinguish those patients from patients with systemic GIA without MAS. Those cells produce a high amount of interferon gamma, and also they correlate with laboratory parameters of disease activity and also with circulating levels of disease biomarkers such as CXL9 and IL-18, and also with disease activity score of MAS. So this is another project that has been already concluded. It's a project led by our colleague in Münster with the aim to differentiate identify biomarkers that can help a clinician to differentiate MAS from other inflammatory conditions. So we know that is again every day very challenging because it's very difficult to differentiate different hyperferritinemic syndrome. So in this study, they collected samples from patients with primary HLH, secondary HLH, and systemic GIA with MAS. And they evaluated, measured those biomarkers in a discovery cohort. They measured 55 different biomarkers, and actually they found that IL-18 S112 can clearly differentiate patient with HLH, secondary HLH from SGIA, and also the IL-18 CXL9 ratio and IL-18 CXL10 ratio, as well as 112 CXL9 ratio and 112 CXL10 ratio can distinguish this patient. In order to validate these biomarkers, they try to perform the same analysis on those biomarkers in a different population, and the data were confirmed with, as you can see from the data of this of the area under the curve of these parameters. So regarding the ongoing project, I would like to present this. This is the just started project. Is an international collaboration. Came from the last presentation, the last data that I have presented, and also based on many manuscripts that have been performed in the last year that demonstrated the relevance of some biomarkers in the diagnosis of patients with secondary, different form of secondary HLH. But actually, everyone in each lab use different methods, so we actually sometimes are very difficult to compare data collected from different labs. So this project is a PRESS-CARA project, so aimed from a straight collaboration between CARA and PRESS, and the aim of the project is to validate those biomarkers in different labs. So the project is just started, so it's quite complicated, but the aim is to measure some biomarkers in different labs and then share samples between different labs in order to confirm the results on the biomarkers analysis. This project is a different one, is a clinic project. Again, is a collaboration between PRES and Printo, a trial organization, international trial organization. Also, this project awarded a grant very recently, and this is more focused on treatment in systemic GIA and MIS and secondary HLH. So the aim of this project to actually understand the real life experience in treatment in SGIA and MAS and secondary HLH. So we usually use the same drugs, but actually we don't follow any specific guideline when we try, oh my God, when we use them with our patient. Thank you very much. So the first aim of this study to actually understand what everyone does among the Europe and in other countries, and then we would like to try to compare different treatment that we usually use in systemic GIA with MIS, with other rheumatologic condition and secondary HLH. The aim of this project is also to involve not only pediatric rheumatology, but other physicians such as hematologists and intensive care doctors and infectivologists that sometimes follow those patients. So the project will start with an expert panel who will build a survey that will be shared in different centers, and then there will be a revision of literature, and then we collected the data until the consensus meeting in order to conclude the results of the study. So we are going to run another interesting study. This is particularly focused on systemic GIA patients. As you probably some of you knows, there is a very recent complication of systemic GIA that is Lyme disease, that is a very new and a new emerging severe life-threatening of patients with systemic GIA. Patients with this complication are particularly reported in US and North America. We actually don't have enough data in Europe. We actually don't know how many patients has this complication in Europe. So the aim of this project is actually to understand the burden of SGIA-associated Lyme disease in Europe. So we spread an electronic survey among the PRES working party, and we reach around 30 European pediatric rheumatology centers, and actually 15 of them follow patients with this complication, and we collected data from 34 patients. So these are just some preliminary data. As very similar to patients reported in US, those patients are quite young compared to other systemic GIA patients. Lyme disease usually onset 2 years later, the SGIA onset. Then those patients have a chronic relapsing disease, and they have recurrent MIS. Half of them were admitted in ICU. The interstitial Lyme disease is the main common feature of Lyme disease as complication, and half of the patients presented with clubbing in their fingers. Majority of patients have received at least one between L1 and 6 inhibitors before Lyme disease onset. So this is a quite important observation, because there is a very interesting discussion regarding the pathogenesis of this disease, and one of the hypotheses is an allergic reaction to some biologic, but this is not still clear. So I'm going to conclude, just present you this course that we have this year in March in Rome. It was the first Press Academy course particularly focused on systemic GIA and MIS. We have, it was hybrid. We have very 2 full days focused on this disease. We have speakers from Europe and also from US. We have a very significant participation from a different country among the world. And if you are still interested, the content of the course will be available on the Press Academy website for those who are press members for at least 5 years. So you can follow it if you want. And I would like to thank you with a picture of some of our participants of our working party.
That was a whirlwind of important critical projects. Oh my goodness, you guys are so productive. This presentation, all of them, are open for discussion and questions. So I'll start with a practical one regarding the biomarkers and all of the different ratios that you showed the AUC curves for on your ROC analyses. They all looked pretty equivalent on a very quick scan, but what is your favorite biomarker or set of biomarkers or ratio to identify your patients with MAS?
So, I mean, the best biomarkers for patients with MAS is XL9. It's the fastest biomarkers that you can measure, at least in our lab. I know that not all centers can measure it, but now it's becoming more easily to measure CXL9 and is the most specific for MAS, while IL-18 is the real biomarker for systemic GIA. So if you have a gap between a systemic GIA patient for another hyperferritinemic syndrome, IL-18 is the more specific for SGIA.
Other questions? It was too much of a whirlwind. Everyone is just too impressed to be able to think of a question. Here's one from Melissa.
So I'm not a rheumatologist, but so do we think that and I'm sure there are other people in the audience that can also answer this too, do we think that there's actually a correlation between the use of anakinra and the development of lung disease? Or is it just so many patients that have systemic GIA are receiving anakinra at baseline or canakinumab?
Yeah. So personally, just my personal opinion, I don't think there is the correlation, but because there are other new hypotheses on the pathogenesis of this disease that actually we don't know very well yet. So in our cohort, there are some patients that come from low-income country that they never receive any IL-1 or IL-6 inhibitor before the development of lung disease. So actually, we don't know yet very well this complication. This is my idea. But I don't think that there is that the IL-1 inhibitors can cause directly this complication. Probably there are more mechanisms that work together.
Because there are some people that are wanting to switch therapy. So they'll see that they have a patient with systemic GIA that has this lung disease, and they're like, oh, it may be associated with anakinra. So then they switch to a different therapy. But the efficacy of that may be, they just need a different therapy other than anakinra because they may not have whatever disease process is ongoing controlled. I don't know. But it's an interesting question because we don't know, like there's a correlation there, but we don't know if it's causative or not.
Yeah, but actually we know this complication from very few years when before patient didn't receive this drug, and we don't know. But it's more complicated than this. There is a huge study on the HLA DRB analysis on those patients to better understand how the genetic can cause this complication. Probably there are more factors that can cooperate for the pathogenesis, so it's very complicated.
And I'll just point out one other effort that she mentioned, because someone, I think it was you, brought up the soluble IL-2 and how comparing units and things. But actually the effort that Grant Schuler and others are leading, I think, is it with Kara? Is it a Kara effort? Yeah, but they're basically just sending split samples to several labs to compare, so people can always reach out to you if they're interested just to join and see how other additional labs compare. The more the better. So just a point. And with that, I think we'll move on. Thank you so much, Claudia.
Yeah. Rebecca, will you help me get back to the other slides?
I would love to help you get back.
All righty. Thank you for reminding me. Yeah. All right. I will remember to start. Here we go. Here. This slide. You good? So alrighty. Yep. And Despina is going to talk with us about FHL2, FHL3 gene therapy efforts.
So sorry, I will be very brief, so I don't have slides. We have in Europe centers who are preparing gene therapy for perforin. It's GOSH. For MANC 13.4, it was the group of Marina, who has already a program for France, which has in the end not been so far that we really take this on to the European effort. So there is ongoing grant evaluation for a consortium with Toni Kattermann in Freiburg as PI and other Stefan Ehl from Freiburg, Gosch with Claire Booth, myself for Paris and also Zurich. And the idea was to provide better care for these patients on several levels. So we had also the idea to have a kind of registry to have more insights on the natural history with two aims. One, to try if we can eventually go forward to newborn screening in some way. So this would be a great hope, because we all know that the results for patients treated preemptively before they develop HLH is uncomparable. So this is one effort, and we hope that we get the funding to move forward with this on the practical level, but also on the political level within Europe, to have a kind of dialogue with the stakeholders and so on. And there are also family parents associations who join in this effort. And then there was the idea to extend the gene therapy for perforin and MANC 13.4 in a way that patients do not travel, but that the cells of the patients who travel. These are very modest numbers because it's very expensive, so we want to do this 5 patients per disease. And then as time went by, we figured out that the French effort with MANC 13.4 was not as far in the development as we hoped, so that we switched actually. And for the gene therapy that we hope to provide, if we have the funding, it would be more perforin and XLP1, and both would be done at Gosch. So this is the state as today. The deadline of the grant application of a Horizon European grant application was in the beginning of September, so we don't have any answer, and we hope that we will have the funding to carry this on. So this was what I wanted to say. Thank you.
Any questions? Yes, Mike. Actually, you keep this one.
I keep this, okay. No problem.
So maybe this is better over a beer, but so exactly, yeah. So Claire is going to do this at Great Ormond Street, right?
Yeah, Claire Booth, yes.
Yeah, and is this conventional lentivirus and stem cells?
Yeah.
Sort of thing, yeah. So this is...
so for XLP1, it may even not be stem cells, but T cells.
Uh-huh.
Yeah.
Got it. And yeah, these were the efforts we were doing with Bobby Gaspar, and then he went to Orchard, right? And then I think it was Orchard, if I remember correctly, or similar efforts, I should say. And is there a commercial tie-in currently?
It will be academic basically.
Yeah.
But then there is a consensus that we need to have more influence from doctors and less from industry, maybe. And so in parallel with this consortium, where we will have hopefully the funding to do what we want, and I just summarized it, there are other aspects in this project for sure, but we will have also a current effort in Europe to have a kind of consortium to bring forward this discussion on how we continue to profit from academic research, which is always the starting point for all these new therapeutical aspects, all these gene therapy trials. And we now see that industry is not always very interested in carrying on. So there was the example for the ADA trial of gene therapy. There were 2 vectors, I mean, it's not HLH, but just to give some insights. There was the old retrovirus, which is used still in Milan, and this was commercialized in Europe under Strimvelis, but commercialization will stop, and the lentivirus is dead because OSHA didn't want to go forward with this. So the academic community and physicians and patients organization, they really feel that we need to have more influence, to have ideally some non-profit academic companies that help us to to go forward with what is developed, so that the patients can continue to profit from it. But difficult question.
Yeah, agree.
And I'll just put in a plug for the PIDTC meeting in April of next year. There's going to be a session that Claire Booth is going to speak at, along with Don Cohn and some leaders from industry and the FDA and the bespoke consortium surrounding trying to get academic avenues of opening clinical protocols. And Claire and Despina and others are really spearheading this effort with the EMA in Europe.
Yeah.
So that's it.
And then I have one question for Despina, which is, you know, at St. Jude, there's a lot of effort now in actually genome editing, right? And trying to edit the genome for patients with sickle cell, increasing fetal hemoglobin, trying to improve sickle cell manifestations. And I recognize gene editing is very complicated, but I was curious to know if there are efforts being considered for gene editing. And obviously for each mutation, it makes it very challenging, but thinking about perforin, right? There's a common, you know, perforin 50-delta in African Americans, it can be challenging to have, find donors for transplant. And, you know, would there ever be an effort to try to correct the most common forms of, you know, FHL2, for example, by gene editing?
Yeah, I didn't go into all the details. So if we have funding, there will be, with Tony Katterman and also Claire Booth, there will be some efforts to go further in this direction. But as I don't know if the funding will go on. But sure, it's important for the future.
Cool. Thank you so much. Thanks, Despina. All right. We are going to move on to our last presentation of the session. We're really honored to have Nirali Shah here from the Pediatric Oncology Branch, who's going to speak about CAR T cells and associated HLH. So thank you so much, Nirali.
Thank you, and thank you for the invitation to be here. All right, so I know that I'm the last speaker in a very long day, and I think we're probably a little bit over. So Rebecca, just like signal when we're at like 20 minutes. But I really wanted to just, you know, thank the organizers and thank a couple of key folks in the audience here for inviting me to come here. I'm very much an outsider for the group, but I'm here out of necessity because, you know, CAR T cells has clear complications that are that lead to HLH-like complications that are leading to fatal toxicities in patients who are receiving these therapies. And so the effort that I'll be talking about really emerged out of need. And so I wanted to thank Inge for inviting me to come to speak, and Melissa and Rebecca, who've been a really critical part of this group, and everyone else who's contributed to this. So again, everything here, it's you know, there's no evidence-based guidance. We're learning this as we go along, and we'll talk a little bit about off-label use of anakinra. The objectives are to provide an overview of HLH-like toxicities in the setting of CAR T cells and to discuss the current challenges in understanding and defining and treating this toxicity. And to make sure that all of us are on the same page, I wanted to give at least one slide on CAR T cells. So this is adoptive cell therapy, which is a mechanism to overcome the inherent inhibition of endogenous T cells to target and eliminate cancer cells. So you're taking, you know, for now they're mostly autologous. We're taking T cells from patients, genetically modifying them so that they have the vector that you can see here. That, whoops, where's my pointer? Is there? Right, yeah, there's this will work. And so you can see here that we're introducing this CAR into a T cell that allows it to have the antibody-based specificity to target an antigen on a tumor cell, but comes with the co-stimulatory domain and the armamentarium of T cell-based cytotoxicity. The most commonly used co-stimulatory domains are either 4-1BB or CD28 combined with CD3 zeta, although there's a whole host of new co-stimulatory domains that are being studied. And basically what this ends up giving you is you have T-cell functionality coupled to antibody-based antigen recognition, primarily used for targeting, at least for now, hematologic diseases, but is quickly expanding to other CNS tumors as well as solid tumors. One of the main side effects from CAR T-cell therapy is cytokine release syndrome. And this is a super physiologic inflammatory process that is seen with the CAR T-cells after infusion as they're expanding. It can range from mild to severe and can be life-threatening. And the first manifestation of it is typically the onset with fever. Neurotoxicity, which is termed as ICANS, or immune effector cell-associated neurotoxicity syndrome, is particularly worrisome. And a few years ago, the CAR T-cell community came together to help define systematically across the field how cytokine release syndrome was going to be recognized and how it was going to be graded so that you can at least use a uniform guidance. Because before that, every center had individual grading system, which made it particularly hard to compare comparability of constructs. You can see here the host of manifestations that really are sort of whole body involvement. And tocilizumab, as everyone knows, an IL-6 receptor antibody, is FDA approved for the treatment of cytokine release syndrome. And this happened in part due to the first patient who was treated at the Children's Hospital of Philadelphia, who had very severe cytokine release syndrome, had not responded to the standard therapies that were given. Again, it was really a first experience and wasn't responding to steroids. Got very high IL-6 levels that were detected in the peripheral blood, and tocilizumab really was a game changer. So in terms of sort of what's happened in the more recent years, so there is a host of now just case report and case series. So we started using CD22 CAR T-cells, which are T-cells targeting the B-cell antigen 22. The vast majority of experiences have been with targeting of CD19. And we started to see a very unique toxicity profile, which I'll go into more details about in a few minutes. But looking, that patients had HLH-like manifestations, as we said, as a CRS variant. And this is not in the context of severe cytokine release syndrome. And then there is HLH-like toxicity, or CAR HLH, after CD19-specific CAR therapy, and this is published from the St. Jude group in their experience. HLH has variable time to onset following CD19 CAR T-cell therapy. This other group came up with a whole new name, which was macrophage activation syndrome-like manifestations following BCMA CAR. So now we're getting into different antigens and targets in different diseases. And now we have HLH-MAS following treatment with dasagenlecleucel. In fact, it's so prominently known and known to cause fatal toxicity that this is actually the FDA label for Abecma, which is a BCMA-targeted CAR T-cell called idacaptogene velucel. And in here, this is again from the package insert, HLH macrophage activation syndrome, including fatal and life-threatening reactions, occurred in patients following treatment with Abecma. HLH can occur with CRS or neurologic toxicities. But we're still left with saying, well, what exactly do they mean when they say it's HLH-MAS? Because nobody's really defined it. So we put together a group, and part of that is we wanted to say, well, what is out there? And so we retrospectively looked at 16 papers that were published. I think our cutoff was just earlier this year to say, okay, well, who is reporting in the patients who have had HLH-like toxicities in CAR T cells, what exactly are the manifestations? And so you can see here, the majority have some degree of coagulopathy. A lot of this is completely ill-defined because it is not defined across papers, so we're just pulling like buzzwords that are found in papers. Most of them had pretty profound cytopenias, and for those of you who are familiar with CAR T cells, they'll cause cytopenias as well. Active hemophagocytosis, and this was really based on the fact that they actually looked versus no could be that they didn't look at all because bone marrows may not necessarily be performed in all patients. Hyperferritinemia was a key consideration or key finding. There was not so much hypertension. Hypofibrinogenemia, again, very, very low numbers where they actually reported the data. Some occurred with hypotension, and then there was the onset of infection in a small proportion of patients. And so I think the primary question that the field in terms of CAR T cells are dealing with is this simply a manifestation of severe cytokine release syndrome? Right, I've heard the term hyperinflammation that somebody mentioned earlier, and I think that that is something that we are certainly struggling with. In fact, some of the earliest work that came from Dave Tichy, I'm not sure if he's here right now or not, really talked about the patients, pediatric patients who had received CD19 CAR T cells with the 4-1BB co-stimulatory domain, and they really had, for the patients who had severe cytokine release syndrome. By severe cytokine release syndrome, I mean that they have hypotension, they may be in the ICU, they're needing oxygen support, they may or may not be intubated and having pressor support that is needed. And so what they found was that the patients with severe CRS often develop a clinical phenotype that resemble MAS or HLH. They looked at all key cytokines and they found, comparing their groups, found that those cytokines were also elevated in patients with the high-grade CRS versus those who were lower-grade CRS. Now, low-grade CRS may be just a fever. And so this, but importantly, what they found is that this data emerged from one unique CAR T cell construct. So when we started using CD22 CAR T cells, again, we're targeting a different antigen. We found that, we had patients who had a very typical CRS pattern. And so patients would have, this is a typical CRS. You can see here interferon gamma on the left y-axis, MIP1 alpha, IL-10, IL-6 on the right. You have a patient who gets infused on day 0. The patient gets CAR T cells. Again, they have active leukemia, active malignancy, which also is going to complicate as we start thinking about how to define HLH, MAS-like manifestations in these patients based on what you already heard of as complications. But you can see here patients get CAR T cell infusion. They have an inflammatory response that coincides with fever, maybe hypotension or hypoxia. And then that all resolves and the patient goes on happily, perfectly fine. This patient achieved a complete remission. What we started to see, however, is that there are patients who had the secondary phase. And so in this particular case here, you see, a cytokine release syndrome. Look at the axis and the levels are much higher for interferon gamma. You can see here after the initial resolution, IL-6 is right here in the black. It never comes back up. But then this patient presents with cytopenias, new onset hepatic dysfunction, both in the form of hepatic transaminase elevations and hyperbilirubinemia. Really elevated inflammatory markers. We've looked at soluble CD25 and ferritin and substantial coagulopathy. And this part is being driven by interferon gamma, and in this case, this is MIP1 alpha. Again, you can see here a patient who has sort of this recurrence, and again, you see these levels getting higher and higher, and they're not driven by an IL-6 predisposition. And so in this particular case, and when we're trying to say, well, is it just severe CRS? I'll say that this patient was perfectly well appearing, afebrile, for all intents and purposes, seemed to have clinical resolution. And so when this patient presented with laboratory abnormalities, there was no indication for us to give TOSI, like we would typically think of. And so this has started to, is a pattern that we're starting to see more, and I think started to emerge a lot more with the CD22 CAR T cells. But it certainly, as you can tell from the package insert, is not exclusive to just that CAR. So you can see here the clinical manifestations. So in our paper, we called it CAR HLH. We're going to move away from this term, but I'm keeping it now because that's what we called it. You can see here that CRP did not, so this is looking at patients all who had cytokine release syndrome. And so it's based on, what the day of CRS onset. So everybody's CRS onset might be at different times. So it's saying, well, let's normalize them to their biologic endpoints. CRP did not differentiate between those who had HLH-like manifestations and those who did not. I will say that only patients with CRS went on to develop HLH-like manifestations. The ferritin is so much higher. Not a huge difference in temperature, differences in LDH, ALT, AST, bilirubin, and maybe some differences in hypertriglyceridemia. A caveat there is that we don't have fasting levels, so we're not entirely sure about that data. We also found that there were vast differences in select cytokines in the patients who had that had CAR HLH. In this case, it was interferon gamma. You can see IL-18 is quite elevated. We do see differences in IL-6 if you just take it, but in our supplemental, we actually stratified these patients from those who did and did not get tocilizumab and found that there really was not a huge difference. And I think this is important because in the field, we're starting to use a lot more preemptive strategies to prevent cytokine release syndrome. And so you may get fluctuating levels of IL-6, especially if you're just basing it on the peak, even though it settles out eventually. And then we have, some elevations in IL-15. We did look at total IL-18 and IL-18 binding protein and have very limited data looking at free IL-18 levels. So I think I'm going to reach out to folks because our IL-18 levels that we did check with A2B Bio are really quite elevated in these patients. And so, sort of thinking about this more globally, I think the way we think of it is timing is everything. And so, you have these patients who may have what might be like this HLH and CRS overlapping. And our thought that this probably is a misnomer. This probably is just a really, absolutely a hyperinflammatory syndrome you're seeing as a context of cytokine release syndrome. You treat it like cytokine release syndrome, and if you need to do a little bit more, you should. But calling one thing two different entities is really not where the direction we're headed. But what we're trying to come up with is how do we navigate this, where there is improving CRS and HLH starts, there's a little bit maybe more for clear resolution. This happens about a week later, and then we're starting to see these patterns where it's happening. I got called about a case where this happened at day 50. Patient was totally fine, had achieved a complete remission, really no manifestations, and comes in with a sudden onset of hyperferritinemia and coagulopathies, and ended up having to get admitted because it was quite substantial. Oops. And importantly, the question is, how does all of this impact treatment and intervention? And so if it's treatment concurrent with CRS, we say you treat it like CRS and do additional agents as needed. And I think the field is moving through its preemptive approaches, trying to prevent severe toxicities. And my hope is that we start to see less of this pattern as we get earlier in the treatment paradigm. And again, I think that this might be severe CRS with HLH-like manifestations. But the treatment for delayed onset of HLH-like toxicities really can vary. I mean, I think there's a number of questions, and I think it's going to be inherently complex and individualized based on that patient. In that patient, has CRS been optimally treated? Is there a role for tocosteroids? And I think a lot of it depends on what their clinical manifestations. Is it recrudescence of CRS? Do they have fever, hypotension, hypoxia that is new onset that we think might be IL-6 driven? Then we treat it like CRS. But in afebrile, normotensive, clinically well-appearing patients, many of how they present with rapidly worsening laboratory parameters, I think we're saying, well, we may not want to treat it like CRS and have to really think about distinguishing these HLH toxicities from standard CRS. In terms of, one strategy that we have used is to think about using anakinra. And so shown here is a patient who has a very heavily involved bone marrow. This is pre-CAR. This is TDT staining. This is a patient who had relapsed after prior CAR T cells and presented to us with a packed marrow pre-B-ALL. This is like a 12-year-old. Got CD22 CAR T cells, achieved a complete remission, had cytokine release syndrome. And while this, all of that resolved, this is an outpatient, and we're getting ready to do the bone marrow biopsy, and LFTs are just starting to rise. We take off all the hepatotoxic drugs, not sure what's going on. The lab calls me at 10 p.m. with this, and this is, several years ago before we really recognized it. They're like, he has active hemophagocytosis. Like, oh, well, now this all makes sense. And so this patient, because he was well, we said, well, these were all rapidly worsening. We put the patient on single agent anakinra. Importantly, this patient had a complete remission with a little bit of disease left, what we would call minimal residual disease. We put this patient on just anakinra alone, and this patient achieved a complete remission, full eradication of their disease, even MRD, and had full resolution of HLH as well. And the problem is that, the management of HLH-like toxicities is variable because part of it is we don't recognize it. We're recognizing patients too late. Defining it is critical. And then there's a whole host of things, most of these drugs which are, already mentioned, which we don't really know how to use in the context of HLH-like toxicities in patients who are receiving CAR T cells. In terms of the biologic linked to HLH, so I don't need to tell this group, but I think that just bringing it back to CAR T cells. So with HLH, there is an excessive activation of CD8 T cells, and I will tell you that CAR T cells, when they expand, they are predominantly CD8. And so in this case, they may be appropriately triggered. I think that for us, it is iatrogenic. We are giving patients activated T cells. They're going into the body to target their disease and expanding. And then certainly there's a role for macrophage activation and interferon gamma. What we found in our group with CD22 CAR T cells is that linking that pathophysiology, is we sort of said, well, if everybody has CRS, the patients who are HLH-like manifestations versus those who do not, what is it that is differentiating them? And so for our patients, what was really interesting was that we did not have a lot of grade 3 and 4 cytokine release syndrome. And I think that's important because that allows us to differentiate this toxicity profile a little bit more from just saying it's all severe toxicities. And with that being said, what we found is that these patients, this is their restaging their day 28 bone marrow. And what you can see here is that the patients with HLH who are in red, they have a higher percentage of CAR T cells in their bone marrow. They have a lower percentage of NK cells, and we started to look at the T to NK ratio. And what we started to see a pattern is that these are patients who have, higher expansion and prolonged persistence that is also higher, so that the normal contraction that's happening with the CAR T cells may not be happening to that same degree, which may potentially be explaining these later onset of toxicities and or re-expansion. And then in context with the relative NK cell lymphopenia, it may not be able to mitigate that T cell expansion. And so ultimately where we ended up with is that recognition is absolutely needed to improve outcomes. Primary HLH definitions are really challenging to apply in patients with active malignancies, as you heard, and those who are receiving CAR T cells who get hyperinflamed. Fevers, splenomegaly, cytopenia, they're all part of the clinical manifestations of underlying disease, as well as cytokine release syndrome. And remember, these are patients with relapsed refractory leukemias or lymphoma, so they're very heavily treated. We thought that there is a need to develop a clear nomenclature to describe and capture this CAR T cell toxicity. And I think that what we as a field needed to recognize is that, we're going to have a lot of different antigens that we're targeting, a lot of different diseases. And there may be differences that we start to see, but that we still have to embrace some of the toxicities that we're finding. So based on this, we wanted to improve outcomes for patients receiving CAR T cell therapy, to come together as a CAR T cell field or an immune effector cell field to help provide a framework for how we think about and define these HLH-like toxicities with a strong desire. We felt it was really important to move away from directly calling this HLH, given that there is a hyperinflammatory syndrome, and wanting also for those who are less familiar with this HLH-like manifestations to not go down the pathway of treating it like primary HLH, which we don't think this is. HLH is going to be added to CTCAE version 6 as a toxicity, so I think we're working with them to think about how those can be synergized, to think about when treatment may be indicated and how to optimize care of these patients, to think about the broader differential diagnosis, because some of the patients who are developing HLH-like toxicities are also doing so with progressive and non-responding leukemia, and so how do the two fit in together, and the biology and future research. So based on that, we have a large working group of 30 people that is, that I sort of highlight this because we have adult CAR T cell people, we have those who are targeting 19 and 20, and BCMA and pediatric folks, and those targeting 19 and 22, and we have HLH experts, many of them who are here, and also incorporate our ID teams as well, because we really need to think about how to optimize these patients. Our current term that we're going to call this is immune effector cell associated HLH-like syndrome. In which will be the development of a pathological and biochemical inflammatory syndrome that manifests with features of macrophage activation and HLH, is attributable to IEC therapy, and is associated with progression or new onset of cytopenias, hyperferritinemia, coagulopathy with hyperfibrinogenemia and transaminitis. And what we point out is that while HLH-like manifestations are frequently seen in patients with severe CRS, IEC-HS is often delayed. I'm on my last slide. Is often delayed in onset and manifests as CRS is resolved or resolving, and it should not be used to solely describe severe CRS. We've put together some diagnostic criteria. This is still an ongoing effort, but basically, we need to figure out some way to bring the field together, and I think you've heard this through all the talk today. Early recognition, thinking about intervention. I mean, right now, patients who, providers who call me, they're on they've gotten 4 doses of toci and are on this and are on that, and you're like, it's already too late. So our thought is if you can at least come together as a CAR T cell community with the group of the experts who are in the room here and help us think about it, that we can improve outcomes. So, we said you have to have an elevated ferritin, CRS is resolved or resolving, or there's worsening inflammatory responses despite optimal treatment, hepatic transaminase elevation, hyperfibrinogenemia, hemophagocytosis, and cytopenias, and we tried to overlap to the extent we could as it was applicable with HLH 2004, recognizing those limitations, and then just say a whole bunch of other manifestations that we may see. And so my final slide is that there is a clear and urgent need to recognize that HLH-like toxicities are occurring in patients receiving IEC therapy, and they can be life-threatening. Importantly, the treatment approach to these patients may differ from either treatment approaches used in primary, secondary HLH, or CRS, and our working group is a first step in the path forward to making the diagnosis, establishing a foundation for future research and improving outcomes. I think where we're struggling now is with treatment and how to sort of align those, but I think that we've made some progress. So with that, thank you very much, and I'll take questions.
Thank you, Nirali. It really is a great honor that you came all this way to present this to us today, so thank you again. And I will open this up for questions and comments. And also, while I'm walking up here and then there, I'm just going to make a plug for Nirali that she is an incredibly efficient collaborator and leader, and I have never seen a committee move so quickly.
Hi, thank you for the excellent presentation. I just have always wondered, what is the rate of remission after people develop HLH in CAR T? Because I hear from different physicians different numbers, so thank you.
Yeah, so one of the things that we're hoping will come out of this, and seems to be a common theme, is that we are going to be putting together like a retrospective or some type of registry to understand this a little bit more. Right now, it seems to differ by the CAR constructs. I think with some of the CD19s, it seems like the patients get pretty sick, and there does seem to be, at least in some patients, that they're also having disease progression. Kevin, who is sitting over there, I think you have an abstract that you're presenting, and I think the patients had really poor outcomes overall. For CD22, we were like, well, they're actually doing okay, and they seem to be fine. But I think also part of it was that we started to recognize it earlier. So in our CD22 CAR T cell trial, we've actually prospectively implemented like a preemptive strategy to say, okay, we know these patients, we've figured out a pattern of who is going to develop it, but we have not had problems with having concurrent disease progression. And so I think it really varies. And I also think we don't know. So I think that, this is a first step really to bring the field together. And I think that so much is going to happen over the next couple of years, probably even more fine tuning of the diagnosis. Yeah. Oh, sorry.
Oh. So thinking about pathophysiology, actually, could you go back like 3 slides to the one, the timing is so curious, right?
Do you want the timing slide?
Well, there's the one that shows the up and down. Yeah, right. So the CAR. Go back. Here. Yeah, that one. Right. Okay. So the CAR T cells are actually coming down nicely, right? Yeah. Even though they're a little higher, right, in these patients at the time, I think, right, then these manifestations are sort of centered, right? And so I just and by the way, that difference, even though it's statistically indicated as significant, right, doesn't look super impressive in terms of, let's say, there's more CAR Ts. I assume this is in the blood, right, as opposed to maybe in the tissues, right? But I'm wondering about this and just your thoughts in general about the pathophysiology here.
Yeah. So what I will say about CD22, so I think, so there's another need for standardization. I think that the way CAR T cells are detected in the field is sort of a mess right now. When we looked at CD9, so we've done CD19 in our institution, CD19-22, a combination in CD22. What I will say about CD22 alone is that the CAR expansion overall is almost a log higher than what we see in our patients. So we're like, well, maybe the link is there. Like, maybe they have so much more robust expansion. You're absolutely right that it's not as substantial, but we think like this bottom one right here. For us, this is like 60% versus 80%. We have some patients who have 90% of their T cells being CAR positive by day 14, and our median time to CRS onset is day 7. And so what you're seeing here is sort of the peak expansion happening at day 14. And so I think that what we need to understand is a little bit more about the patterns as it's happening across the constructs and to see what the correlations are. You're right, they are contracting. You would think that this contraction would naturally, but I do think that there's some patients who are having, this line is sort of pretty broad. There's some patients that we've seen have a little bit of re-expansion, or the contraction doesn't seem to be as bringing it down as much as the others. like the slope is less.
And just to follow up, I just realized, yeah, that's percent of lymphocytes. Do these patients develop an overt lymphocytosis, or is this a percent of a really small number?
So some patients have developed a real overt lymphocytosis. It's really impressive.
And does that correlate with the, how do you say this? It's an unpronounceable syndrome. IEC
HS. It's lovely. We struggled. We went through like five. Went through like 5 different options. No, I think we did a survey and we picked. Yeah, it's hard, but not necessarily. You know, because it wasn't the peak that depended. It was how much they hang on to them. I think that was a big issue.
And some of that is like ICANS related too, right? Like the immune effector cell part of the term.
Yeah,
Is this correct?
So we went through, I think, so we did a survey and we came up with like probably 6 different terms. And then people really wanted to maintain the immune effector cell part of it. And nobody wanted to use HLH. And so we now have IEC, HS, which is HLH-like syndrome.
Oh, hi, it's Beth Martin. So my suggestion would be is that you look at the host factors really closely, because if you think about this, if we are inducing an acute leukemia patient who's refractory, those cells are in a lot of different organs, I mean, including the liver. You may have a person who's iron overloaded, so that's you're at a point where you actually may be seeing, in some of the patients, not all, but actually true iron toxicity, because I recall from your paper, it's a really nice paper, but your cutoff is 100,000 for your ferritin. Well, that either means you have a very iron overloaded patient, which many of them are, or you have so much apoferritin out there, and that's not really, well, you know, it's not iron-containing ferritin. So I think that, and also, as far as I know, there's not good data on the cytokine profile in tumor lysis syndrome. And so you actually have this population that you've got this imbalance of T and NK, and they are lysine, even if you don't have the typical hyperuricemia that you would see. And so I think it'd be interesting to see, even in a tumor lysis population, an induction population, to do similar cytokine profiles, because I would anticipate in that population they are really, really exhausted, so they're probably not having a T cell response. If, say, I were inducing a hyperleukocytosis, you know, acute monocytic leukemia. I mean, a really tough one. So I think that, but then I also think there must be, just like they're finding in GVHD, gut microbiome. So your individual patient's gut microbiome, and then for those delays that were out 28 days, that could easily be gut endothelial damage. I mean, so just, it's such a complex population that now you're adding these cells to, but, and again, it could be that even TLS in some form is actually giving you, you know, in some patients, some really odd cytokine patterns.
Yeah, I think your point about ferritin is extremely well taken. Well, our patient's baseline ferritin is 5,000. I mean, that's, you know, we can't use the HLH cutoff to begin with. And we also made it very clear for our criteria that we didn't want to have a ferritin cutoff because it's really, really broad. And I think the thing that I find really interesting is for those patients who have the very late onset HLH, when they're in remission. And so you're like, what is going on? Because at this point, this patient should have no disease. And so I think you bring up really excellent points. And again, it's like the tip of the iceberg.
Can I make a comment? Yeah, I wanted to make a comment in that regard too. You know, I don't know how much you're looking at the myeloid cell compartment, but you know, you've shown that the T cells go up and they go down. And we had this interesting observation, Sabrina and I, when we were doing our mouse studies, comparing interferon gamma neutralization to treatment with ruxolitinib. And we actually, instead of doing continued treatment, you know, we infected the perforin deficient mice with LCMV, and then we started treatment with either ruxolitinib or interferon gamma neutralizing antibody. Then we stopped the treatment, okay? And both cohorts of mice, so very short-term treatment, both cohorts of mice did well in the beginning. The ruxo mice continued to survive, and the gamma mice later started to look bad and die, and it turned out that they have more of an innate immune activation. So I think like it would be really interesting to look in the patients, you know, what's happening to the myeloid compartment in the blood, you know, the numbers, the phenotype, the functionality, the cytokines, because I think you showed there was MIP-1 alpha, and it's almost like, I think that's what was up there, but it's almost like that later hyperinflammation is more like, you know, secondary HLH in the sense of could it be innate immune cell driven, and you need to target that, and that would make sense with the anakinra response, right?
The the other thing I wanted to make clear is I presented data on CD22 where, my group has the most experience, but I think one of the problems is we don't know the true incidence of this. It's like across, some CD19, so it might be that it's 10%, and so there's a component that you're like, well, is it idiosyncratic that we just don't know which patients are going to develop this? Okay.
Thank you. Thank you for this excellent presentation. Papadakis from Athens, Greece. You talked about CRS, but you are not going to touch ICANS and how to diagnose and treat that in that relation, and incorporating your filament light and the new work that has come up?
Yeah, so ICANS and CRS are both now defined. The ASTCT put those two together, and so there is a clear set of criteria that are used to diagnose cytokine release syndrome. There's a clear criteria that is used to diagnose ICANS. The treatment approach for ICANS is still a little bit variable, but there's sort of a general approach about how you think about it. And so what we don't have is now this component to say, well, who are the patients who are developing HLH-like toxicities? How do we define them? Because until we define them as a group, we can't study them. And I think that's what we really need to do to be able to answer all the questions that were raised.
Thank you.
All right, everybody. Thank you so much. Yeah, thank you, everybody, for sticking it out. Thank you, Nirali. All right, have a good evening. We'll see you all at the welcome reception.